I'm David Radbourne, Chief Operating Officer at Chelsea Westminster.
My name's Paul Sullivan. I'm an acute physician at Chel West, and I also work for the Clerk for North West London in a quality improvement role.
So we've prepared a few slides for you, but we weren't proposing to talk at you for 40 minutes because my suspicion, having looked at the agenda, is that you've had a little bit of presentation time already today. So this, just for kind of preparedness before the coffee kicks in about, roughly speaking, 10 to 15 minutes, it will go into interactive mode. So be warned at that point, at which point you'll either be deathly silent and we'll all go for a coffee early, or alternatively we can compare and contrast how it feels across London to be running emergency care services. But we were asked to prepare just kind of like a primer, if you like, for how it seems to feel from our perspective at Chelsea Westminster in trying to manage 4-hour flow across an organisation, because it's not a A&E department specific target. It's a barometer, as I'm sure we all know, about how well we can manage flow through the organisation. So we'll take this in turns just to take you through some of that. But for those of you that don't know Chelsea Westminster that much, it's on the Fulham Road in Chelsea, funnily enough, as the title would suggest. It takes, roughly speaking, an hour and 5 minutes to get here from that neck of the woods, especially if the Central Line is slightly flaky, which it is today. So if you're going home on the Central Line, you might just want to know that. But in terms of the organisation, it's 350 mil turnover. It's got a mix of what you traditionally call as DGH plus specialist wrapper. So we do have specialist burns, specialist paediatrics. We are Europe's largest HIV provider. Did anyone know that? Did you know that we diagnose 1 in 3 HIV cases? I didn't know that before I started. It's a rather interesting fact, I thought. We've got a big and busy maternity unit, but also quite a vibrant private practice that goes with that, particularly around maternity and growing paediatrics. We're North West London's surgical centre for paediatric surgery, but also have a growing presence in the community. Now, we're not an integrated organisation, so I suspect some acutes in the room. Who's from an acute? Put your hand up. And from a community provider arm of whatever description? Social care? Commissioner? Intermediate tier, or whatever you call yourselves nowadays? NTDA? NHS England? Marvellous. So we've got a bit of a spread of everyone, haven't we? So we haven't vertically integrated, but what we have done is spread our tentacles a little bit further out in terms of winning musculoskeletal contracts, community dermatology, and so on. In terms of our overall activity, we'll come on to it later, but a reasonably hot site. We've just cleared off 112,000 A&E attendances last year. So reasonably busy in terms of throughput through a, roughly speaking, 500 bedded base. That gives you a little bit of our fabric. Over to you, Paul, for this.
Can I have the next slide? The topic of this talk is how we manage the whole hospital to maintain good flow and good 4-hour waiting times. And I suppose I could go through quite a lot of the different little bits and pieces that we have in place in Chel West. And I guess each one of them is no better than what people have in other places. So what might be quite useful at the end of this slide is if we have some feedback from the room on whatever schemes that you have in place to improve flow and throughput as well in your acute hospital. So if I go through little boxes from the top, we start with top left with the general practitioners, and one of the things that we're putting in place is that the acute admission calls for medicine, which is obviously the biggest bulk of the admission flow by far, will be going to a consultant rather than one of the junior doctors. And what that means is that we believe quite a lot of those admissions will be able to be diverted in some way. So I've been at Chel West just since September, and before that I worked in Salford, so I've got more experience actually from the north of working in this way. And so we had a scheme whereby a consultant physician got all of the calls, an acute physician got all of the calls from GPs, and quite a surprisingly high number we were able to divert in some way, either to, we could say this is not urgent, but we can see them tomorrow or this afternoon in a hot clinic. Quite a few of them were inappropriate because it was something that didn't really need an acute admission. For instance, anemia. We found that a lot of the calls are for anemia, and we were able to signpost them to either do the tests themselves or put the patient on iron for iron deficiency anemia. Quite a lot of the things, for all sorts of reasons, didn't really need to come into an acute service. But the way that it would work in a traditional system is that the patient would come up, all of the sort of admission paperwork would need to be done. They wait for a long time. They get clerks, they wait, they get seen on the post-take ward round, they get sent home, or they may stay overnight if all of that's happening in the latter part of the day, which not only is an issue around flow and bed occupancy, but it's also a pretty poor patient experience to be told at the end of this 12-hour process that you never needed to be here, you just need to take some pills. So by and large, we believe that that has a big impact on experience, flow, occupancy. In Chelsea and Westminster, there is an urgent care centre, as there is in lots of other places, but I think one of the things that Chelsea and Westminster does is it triages some relatively high acuity patients into the urgent care centre. So as I understand it, for instance, appendicitis would go to the urgent care centre. So the GPs in the urgent care centre are seeing a good proportion of what would traditionally be seen as type 1 ED work. And that leaves the majors and minors part of ED a little freer, and there are GPs and advanced practitioner nurses, I think, working in the urgent care centre, so there's quite a lot of activity in there. ED, one of the things about ED at Chel West is that it is relatively small, and the majors area is relatively small. I can't remember how many beds or trolleys they have. Ossian, do you? 12. So for quite a heavy, it's got quite a large number throughput, the ED, and I think having a small number of beds does actually encourage flow through rather than people accruing in ED, because the pressure is on ED to get people through. They have a EOU, which is the sort of EOU observation unit. I had a little TIA there. And so the EOU, they're very strict about who goes into the EOU, because my experience in the past is that that sort of unit can be a breach avoidance unit, and all sorts of things can go in there, and often patients who are clearly going to be admitted, and then they get referred on to medicine or something later or the following day, and then they have to start the admission process again, and it's probably quite inappropriate. And as it's part of, this is my own experience from elsewhere, as it's part of the ED and often staffed by ED, people who go into ED don't want to be doing heavy elderly care nursing, and so the staff become demoralised. But this EOU has very strict criteria for admission. It's very small, and a consultant and a senior nurse have to agree before a patient can go into there. So instead of being a sort of cul-de-sac, and a breach avoidance cul-de-sac, it is actually used correctly. Then AAU, which is where I work, so obviously this is the key to the... But I mean, one of the things about the AAU at Chel West, which is slightly unusual but not unique, is that it's quite big in relation to the take, so that we have an average take of 30, 35, but the AAU is 50 beds. So what that means is that the recommendations are that you have an EAU that's the size of your take at least. We have one that's bigger, and what that means is we're able not only to deal with the take, but all of those patients who are going to go home the next day or 2 days, we can say they can stay here. And in doing that, we probably send a lot more people home more quickly, because there's that thing that if you see somebody on day 1 and then you come back and see them on day 2, it's really easy to go, oh, you look better, you can go home. But if they've gone to a ward and the second person seeing them didn't see them before, they're sort of starting from scratch. So that probably makes a big difference, I think, to flow. I mean, what we do know is that people who go from AAUs generally into the general wards probably stay longer than if they went home, you know, if they had stayed on EAU. That's sort of anecdotal, but I think there is that catching up period of at least that first day. The other thing that we do on AAU is we have a level 1 area on AAU. So we've got 9 beds that we can either bring people into from the rest of the hospital, which is very good for patient safety, but it also means that we can manage our own patients who are sick, and because it's co-located and it's run by the same doctors and nurses, people can go in and out of the level 1 area rather than the usual linear flow. You know, you have to call the anaesthetist and get somebody onto HDU, and then when they're on HDU and need to come out, they have to find a bed in the hospital. We're quite good at shuffling people sideways, and I think that probably does something for flow as well. Going on to the general wards, we're very, very strict about designating people on AAU to go to the right specialty. And, I mean, we do know that if people go to the right specialty with a variety of conditions, and probably all conditions, they get a shorter length of stay. So there's good data that if somebody goes to a chest ward with COPD, then they will have a shorter length of stay. One of the issues that we probably do have, though, is that with community and social services, because we're not integrated, not vertically integrated, it would be that's an opportunity that we probably haven't stepped up to yet, because we do have problems with moving people out into social care. So that's a sort of picture of what we do in Chelsea and Westminster, and how some of the things that we do to keep people moving through. So I thought perhaps if anybody in the audience has any...
Just finish off the rest of the slides.
Oh, yeah, OK. So
Yeah. And then that will give a better flow. So the question really is, does that work? Which is trying to get the right people seen at the right point of their journey promptly by senior people. And I guess the bit that could be accentuated in that slide is that we've consciously invested in, over a number of years, a lot of senior medical input at each of those stages. So whether that's consultant cover in AAU, whether it's consultant cover paediatrics and adult in A&E department, then those are things that we've prioritised, which is, I guess, reflected in how we came out of the AES standards. But the question, I guess, is on does it really work? So we've just put in some slides that you've probably seen before around national performance, which shows some variability down to 90%. I'm sure a lot of people have felt that. And then this is London, overplayed on that, down to 89% points. And then that's our run chart. So we do have some bad days. I kind of flog myself when we hit 95.9 and tell myself I really ought to do better and reflect on the breach analysis. But it's pretty tight. And I think, you know, people often say, you know, people, when it all gets a bit tricky, what is it about Chelsea and Westminster that works? And there, sadly, for this session, there aren't any kind of magic bullets where you just go, well, if I went away and had one of those, then I too would have recurrently, I mean, what is my year to date? 98.6, I think, at the moment. It's because of the sum of those parts that Paul was talking about that delivers it day in, day out. So it's embedded in the clinical team culture. It's embedded in the flow design from start to finish. But it's not that we're without problems, because as we'll touch on later, we, as of last count, have 29% of our bed stock that could be used in a much better way, or ideally not be there at all. So we'll come back to that. So this is your slide, just a couple more to go.
Right. So I guess, I mean, these are some of the things that we need to respond to keep flow moving, and we need probably to be inventive in how we respond to those things. The flow is linear, and you know, if we look at the theory of critical constraints, there's always going to be something along that line that's blocking flow. And for us, getting people out is an issue. But also, there are several steps along the way that we can move things along. And the way to have lower occupancy is to get patients onto the next step and out of the hospital at every possible step. And I think that the important thing is that that has to apply to all patients. It's quite common to look at our patient stock and say, you know, there's a small proportion of patients who are 90-day stayers, and they've got these particular complex social problems and so on, and really focus very hard on working on those patients and moving them out. And that, then obviously that's the right thing to do. But the other thing is that if you could take 4 hours off every admission, if you're putting through 30 or 40 a day, that adds up to a reasonable number of beds. And if you can also move people, get them through the steps that they need before they need to be discharged quicker and efficiently, you could maybe take days off an admission. So the difficulty is that our system isn't really set up to deal with the patient flow with that kind of urgency. Not our system, but the system, the global system. And very often we have to respond to peaks and different bespoke problems on a day-to-day basis. And ideally, we can always predict that these things are going to happen. You can actually mathematically model how many days of the year you're going to get 60 people in, how many days of the year you're going to get 70 people in. We still have to, when those things happen, respond to them and firefight in a way. And that's something that I think that the management team at Chelsea and Westminster respond to very well. So that there is a our site managers are very senior, so they are paid very well, I think. Is that right? Are they 8Bs or 8As or something? 8B? I understand that that's quite a high sort of grade for epic grade for but they are extremely good, and they're they're very mature managers, very effective, and deal with things as they crop up in a way that works, in a way that's good. My experience in other hospitals has been that whenever you can tell what the bed situation is by looking at the number of people with clipboards looking at the board in AAU, and also what they're wearing, because as it goes from ward managers to matron, and then people in suits, right? But we never have that at Chel West. It's actually what we have, because of course I've never really they must know how it works, but I've never really understood our staring at the board. I'm sure they know what they're doing, but we never get that in Chel West. We get a useful, considered response. We don't get panic, we don't get pressure, and we get people sorting these problems out. So all of these things happen. We get spikes in demand, we get beds full on the downstream wards, we get lots of social care delays, but we seem to manage with the peaks very well.
So that's really helpful, just playing out some of the challenges, and I think probably most people in the room recognise that as a day-to-day reality. We do have those days where we all fly around on a black day, and Oshin will remember that, as our previous general manager for the service. So just to sum up, there's two slides now. So there's something in terms of how we have designed consciously a operating system that works, generally speaking, day in and out. And that's about senior experienced site managers that are empowered to make real-time decisions that improve and act on the flow of the organisation. It's about an operating model on AAU that enables swift and timely decision-making. It's about senior presence clinically in A&E on the AAU, and also now 7 days a week in downstream wards, because you've got to get the flow right. But the thing that I observe is it's an embedded culture, so people don't kind of come in on a Monday and go, mental note to myself, I probably ought to try and minimise the number of waits and delays for a patient that they will be caused in order to achieve a target standard. There's a general aspiration at a clinical level and an operational level that waits and delays for patients are a bad thing. We need to design systems that iron them out and prevent them. We're not perfect, but it works reasonably well. And then that runs day in, day out, and then you manage by exception events as they turn up, and they always do, don't they? So you might have a large number of patients that require psychiatric assessment. It seems to be one of our challenges, really, that's grown over the last 6 months. So the vast majority of our breaches are that type of case mix, and then you've got your clinical, complex clinical cases that take a bit of time. But we do look daily at the root cause around other preventable, what I would call preventable delays, which is, it took some time for a doctor to come down and assess from plastics or whatever, and use that as an opportunity to iron out waits and delays. So there's a sense of ownership and continuous improvement cultures there. But as Paul's alluded to, we're kind of not fully there yet. So Paul's been piloting a project on the AAU where we still have patients waiting the results of a test. Perfectly fit and healthy, could probably wait for the results of the test at home under your care. So that's exactly what you've done, isn't it? That was 10 patients, at any given time that could be at home rather than AAU. So that's been a really good development, and I think having the relationship with CLAHRC that we host has helped that. I think where we're going next, and it probably has been trailed through some of the content today, is a real quest for the next step. So 29% of our beds currently have patients that could be in a different health or social care setting, whether that's in a community resource, whether that's at home, whether it's the next step of their pathway. And that's the bit that we're now seeking to design, is I have no interest in increasing the number of acute beds in my organisation. I'd actually quite like to reduce them. So in partnership with the CCG and CLCH, who's our community provider, we set ourselves the goal this year, given that we also have 20% of readmissions that are preventable, of reducing admissions by 5%. That's in my contract for this year, with a sequin target attached to it, but also a goal to close a ward and get that quantum of at least part of that 79 bed stock, 29%, where patients actually be in the right healthcare setting or social care setting for their needs, as opposed to being warehoused in an acute organisation. So that's pretty much where we are on the journey of improvement.